Hello, my name is Kelsey Harper. This is my collaboration and leadership reflection video for NURS FXP 4010, Leading People, Processes, and Organizations in Interprofessional Practice. In this video, I will recall an instance of interdisciplinary collaboration, pointing out ways the intended results were attained both successfully and unsuccessfully. I will provide examples from literature to illustrate how ineffective collaboration can lead to poor research management. I will identify best practice leadership strategies that would improve an interdisciplinary team's ability to achieve its goals. I will communicate this in a professional manner and provide 3 sources that are scholarly and peer-reviewed. Interdisciplinary collaboration experience. To start off, I will provide some personal information to provide a personal collaboration situation that I had. I am a 2022 graduate from Eastern West Virginia Career and Technical College Associate in Nursing program. I have been an RN for about 2 years, with all to most of my experience being in an emergency room setting / triage setting. I was a tech in the same ER for years and did my clinical rotations through it, and now I am a nurse working there. I do mainly triage shifts now and work alongside many doctors who do 24-hour shifts. One night, my ED was super busy. We were holding patients for bed placement, and there was a full waiting room. I work in a 12-bed critical access care hospital in Royal, West Virginia, and when we have super busy days like this, it can be overwhelming to the physicians because we only have a PA or a nurse practitioner until 9 p.m. This particular night, we had many EMS calls, and we were full. They called in and stated they had a 32-year-old female near syncope with nausea and vomiting. I immediately looked for a bed to place this patient in and realized the only bed we deemed the trauma room. We try to keep that open for codes, etc. The physician heard the EMS call and told me to place the patient in the waiting area instead of the bed. When the patient arrived, EMS was made aware by the physician to take the patient to the waiting room, and I could get report and assess in the triage room. EMS immediately told me that they felt this patient needed to be in a bed, that her finger stick blood sugar was unreadable, high on their glucometer. The patient was seated in the waiting room profusely vomiting in front of all the other patients in the waiting room and stated she felt faint and was very clammy. I advised the ER crew to bring the patient back to the room. They brought the patient to the trauma room, and I took report and obtained her blood sugar, which again read high, just as theirs had. The physician came in and aggressively asked me why this patient was in a room due to being full, when he specifically asked that the patient go to the waiting area. I calmly explained to him about her blood sugar and vomiting and how she had a syncopal episode for EMS and near syncope in the waiting room. The physician stated he would get to her when he gets to her, and did not listen to what I had to say about her simply because his request to put her in the waiting room was denied. I was persistent, seeing how this patient was nonstop vomiting and her sugar was exceptionally high. The physician then did blood work and got a urine and determined that this patient was a type 1 diabetic and active DKA, diabetic ketoacidosis, and severely dehydrated. Poor collaboration and impact on the patient. Even though the patient got taken care of and everything turned out okay in this situation, the provider's communication was poor, and his determination to send this patient to the waiting room without report was poor. This led to delay in patient's care. Figuring the whole situation out took 30 to 40 minutes of delay when this patient could have already been taken to a room and taken care of. The ED is about critical patients first, and sometimes physicians forget to give thought to that if they are not actively coding. The patient was very ill and passed out multiple times, and her care was delayed due to lack of communication, and medical decisions was delayed from the doctor. It was very important that the healthcare team communicates thoroughly to have the best outcome for our patients. Best practice leadership strategies. Effective leadership strategies can enhance interdisciplinary teams when managing a patient with a history of type 1 diabetes. Promoting good, open communication between nurse and doctor is important for the patient as well. This comes from an article by Corey Fry, 2021. Providing research and respect to each other on the healthcare team and the patient can go far to providing good care, which is why we do what we do in the first place. It is so vital that each team member performs their role in healthcare. RNs are the ones who see the patient first. In this situation, get your report on said patient and obtains a history. As Van Dorsen and Boog said in an article from 2020, a skilled leader practices autonomy and trust what each team member brings to the table. By allowing each member, such as an RN, respiratory therapy, radiology, etc., make decisions based on what they are specialized in, for me, triage, the leader supports responsibility and accountability to each member. Best practice interdisciplinary collaboration strategies. Interdisciplinary collaboration can be successful when each member of the healthcare team shows mutual respect for each other and have honest and open communication and feedback from one another. Although there was good communication from myself and the EMS team, there was certainly room for improvement from the time EMS called in with the patient until she was treated and discharged. I will attach my resource sheet. Thank you.